Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and thank you for tuning in to another episode of Breast Cancer Conversations. I am so excited about today's episode with Dr. Tammaro, who is going to help us unpack everything we need to know about breast surgery, from a lumpectomy to mastectomy to reconstruction options to going flat, understanding what clear margins are, and everything in between. Welcome to the conversation.
Thank you so much for having me. Yes, my name is Dr. Yolanda Tamero. I am a breast surgical oncologist. I work for the Premier Surgical Network in New Jersey, as well as Hackensack Meridian Health Ocean University Medical Center.
I just want to start off right off the bat because I feel like I don't understand all the differences between the types of surgeons and the people on our team, right? You could have a breast surgeon, you can have a plastic surgeon. And in my case, I actually worked with an oncoplastic surgeon. And so would you have an opportunity to maybe just define who these players are as we build our teams?
Absolutely. Typically, when a breast cancer diagnosis is made, you will see the breast surgeon or breast surgical oncologist first. So the breast surgeon is pretty much the leader of the pack, okay? As a breast surgeon, our focus is eradicating the cancer. So basically making sure that we remove all of the cancer, get our clear margins, which we can talk about what that means in just a few, check lymph nodes if necessary, do whatever it is necessary as part of the oncologic process of the surgery. Okay, so that's what we're most concerned about. Now, the breast surgeons also do very much care about aesthetics as well. And we have techniques to make more aesthetically pleasing surgical choices, and we have the capabilities of doing that. However, when the surgery is a little bit more involved, and let's say a patient is having a surgery that requires a reconstruction, then we have our plastic surgeons join the team. And so the plastic surgeon will deal with purely the cosmetic aspects of the surgery, not the cancer aspects or the oncologic aspect. And an oncoplastic surgeon can be a few things. So breast surgeons do know how to do oncoplastic techniques. So sometimes I can do my own oncoplastic technique, which means combining cancer surgery and plastic surgery at the same time. Other times, the plastics part of the surgery is a little bit more involved, and that's where we get the plastic surgeons involved too. So oncoplastic surgeons are typically plastic surgeons.
At survivingbreastcancer.org, we also run support groups every Thursday. And we always talk about our peer-to-peer experience and our personal experience with breast cancer. And some people get diagnosed with breast cancer, and immediately the first people they see are their surgeons. Other times, and I'm not a medical expert by any means, but my understanding is that if you're HER2 positive or perhaps triple negative, you might start off with chemotherapy first, followed by surgery. Do I have that correct?
Correct. Typically what will happen, that's why the breast surgeon really is the leader of the pack, is because when the diagnosis is made, if someone is coming to me as a first-time patient and so, they have a triple negative breast cancer diagnosis, it is my responsibility to direct them to the medical oncologist. Because certainly most of the time for triple negative breast cancer, chemotherapy is a part of the treatment plan. And oftentimes that chemotherapy will happen prior to surgery, which is what we call neoadjuvant treatment. So it's the responsibility of the surgeon, if you are seeing the patient first time, to know that this is a type of breast cancer that we shouldn't take to the operating room right away.
So when you first meet with a patient, can you walk me through a day in the life, right? So I just come into your clinic. I am a mess because I just found out I was diagnosed with, let's say, early stage breast cancer, because that most likely is treatable through surgery versus metastatic disease if it spread to other parts of the body. My understanding is that because it has spread to distant locations, surgery is less so of an option, correct?
Correct.
Okay, so I'm early diagnosis. I'm in your office. I am holding back tears. Tell me what to expect.
Well, in terms of how I run the show, when there is an early stage breast cancer and the prognosis is excellent, with what we're seeing, 99% 5-year survival rates, 100%. I start off with that, especially if I see that the patient is teary-eyed and clearly anxious. I introduce myself and I'll say, just so you know, before we talk about anything, you are going to be just fine. And that usually you see, yes, exactly that,
yes.
That sigh of relief. And, then I tell them, this is the toughest consultation you're going to have because it's the longest and it's the most information that will be thrown at you at one time.
Okay.
But I also tell them you should feel better walking out of this office than you did walking in. So those are a few of the ways that I try and, ease some of the patient's anxiety. Then we'll start going into what the breast cancer is and the treatments and all of the spiel from surgery. I'll talk to them about radiation. I'll talk to them about hormonal therapy or chemotherapy if it's needed, usually not for early stage breast cancer. But that's kind of how I started, just to kind of get the patient more comfortable so that they're actually absorbing all of the information I'm going to be giving them. Because if you're at that heightened level of anxiety and an emotional mess, like you said, you're not really going to absorb what I have to tell you.
Exactly. Yes, I heard the word cancer, and then everything else is like in one
Which
ear
is
out the other.
Reaction. That's a normal reaction. That's another thing that I tell the patients. This is a normal reaction. You're teary-eyed. You're anxious. Everybody is. There's nothing wrong with you. It would probably be a little bit alarming if there was no reaction at all, right?
Sure, exactly.
Evoke an emotional response.
Mm-hmm. So there's reassurance, there's validation, there's, letting the patient know the statistics that, that you're going to walk out of here feeling better and empowered with information and to digest it all. So I appreciate that.
Correct. Absolutely.
From your experience, what type of questions do patients typically have when they're meeting with you? Is it first to hear all of the options available to them, or do they come to you first with oh my God, am I going to die? Who's going to take care of my children? Or we need to have surgery tomorrow because I need to get this cancer out of my body? Or is it more aesthetic also? Oh my gosh, I really identify as being feminine and my breasts are part of my femininity. What do we do about that? And I'm really worried about that. And what my husband's going to think, and some of the sexual intimate relationships that we have, et cetera. So just from your anecdotal experience, are there major concerns or themes that you've experienced from your patients?
I think the most common one of all of the ones you asked tends to be, am I going to be here for my children? That's a big one. That is first and foremost. Or even, breast cancer is mostly diagnosed in postmenopausal women. So a lot of times it will be, I want to see my grandchildren grow up. That's a big one. And so that's why, to start off with, well, this is early stage and you're certainly going to see your grandchildren and your children thrive and you're going to be able to take care of them just fine is important. Yes, is this something that I'm going to die from? Is a question that I hear often. And then, yes, aesthetics also. That's very personal. Some women are very interested in that part of the talk and some women are not. And so sometimes they might, what I find is you might not be interested in how you're going to look cosmetically because all you care about at this point is getting the cancer out.
Yes.
And they'll tell me do whatever you need to do. I don't care what it looks like. And I'll say, no, but I care what it looks like. And at some point you might care what it looks like. You might not now, but we can offer you both. We can cure your cancer and we can also make you look nice. So let's keep that in mind. It's not harder for me. This is my job. This is what I do. So that is important as well. I think the number one though is, am I going to be here for my children and my grandchildren? I think that's the number one question I get asked. And the other one that you touched upon is, I need to get this cancer out tomorrow.
Yes.
That one's universal.
Right.
That one is universal, but that's also that's where, my role is very important to explain to the patient 1 week, 2 week, 3 week is not going to make a difference, me putting you on the operating room table. But oftentimes, and actually most of the time, additional workup needs to be done before we can get you to that point. And it is incredibly important to cross your T's and dot your I's before you're on the operating room table. Because ideally, we would like to do this one time.
Right.
We don't want to take multiple trips back to the operating room. And we don't want to see something 6 months down the road that we missed. And now we have, so there's other tests that need to be done, sometimes like MRIs or genetic testing, things like that. And there's time to get that done. The cancer is not going to spread like wildfire in the time it takes for us to get, an additional imaging test or a blood test. So that is also something I have to definitely ease the patients into and explain to them that it does not need to be out tomorrow. You are going to live just as long as if I take this out in 2 weeks versus tomorrow.
To linger a little bit on some of those other workups and tests that you're looking for, can we dive into that a little bit more? So what are you looking for with genetic testing, and how would that change the outcome of the surgical options? And what was the other test that you mentioned? The MRI.
MRI, yeah.
Yes.
The genetic testing is very important. So when we see women with a family history of breast cancer or ovarian cancer, we start thinking in our head, potentially there's a gene that could be causing cancer. Only about 5 to 10% of breast cancer are actually due to this gene, so they're rare. The genes are the two that we discovered first are the BRCA or BRCA1 and 2 genes. So they have a very high lifetime risk of developing breast cancer if positive. That's about, some studies will show up to 80% lifetime risk of developing breast cancer. Now, an important thing to understand is we all have these genes. We need them to survive. But it's something called a mutation within the gene that, if that's there, would then increase the risk of breast cancer. Since we discovered the 2 genes, BRCA1 and 2, we've discovered 7 more that we test. And so that's called full panel genetic testing. So 9 genes are tested. And the other 7 genes, the risk depends on each gene. There's varying levels of risk. Now, it is important to have that information prior to surgery for some women, because knowing that there's an increased risk of developing another breast cancer higher than that of the general population may affect the patient's surgical choice. And so sometimes some women, especially in the younger age groups, choose to do something like a double mastectomy with reconstruction, not because it's medically necessary to cure the breast cancer, but we're doing it in a prophylactic type of way. So they reduce their risk of developing breast cancer again by the most they possibly can. So that's why I like to get that test prior to surgery. But I will explain to the patient that, having a gene doesn't automatically necessitate you to have a double mastectomy with reconstruction. We still can go the more minimally invasive route surgically. It's a personal choice. And I just have to explain to the patient the statistics and the risk. And then we make that decision together. So typically the genetics will take about 10 to 14 days to get the result. Well, I will draw the blood the day that they see me so that the ball is rolling as fast as possible. The second part is the MRI. So we use MRI on a lot of patients that get diagnosed with breast cancer through mammogram and ultrasound and then biopsy. MRI is especially good for women who have very dense breast tissue. It takes a more in-depth look at both breasts to ensure that there's no other sites of cancer that potentially the mammogram or the ultrasound could be missing. And I think that's breast density dependent and also age dependent. And so we choose who, really needs the MRI prior to surgery as well, because that could influence the surgical choice too. If we find an additional area, we may have to alter the surgical plan.
That was going to be my next question. So during the MRI, you'll look at both breasts, not just the one breast that presented with the cancer and the tumor.
Correct. Universally, MRI is always both sides.
Yeah, I went through genetic testing myself, and I think I had the 7 panel as well. They were checking for like the ATM gene, PELB, CHEK2, et cetera. And I remember it also being a little bit of a contentious conversation with my relatives and my family, knowing that that I'm choosing to get this information. But then once I have the results of this information, sharing that with my family members, whether or not they wanted to know or not know, they didn't have to open the envelope. But at the same time, it's empowering, especially as I have a lot of female cousins, I have nieces, it just is one of those things that, yes, they're my genes, but they also get passed down. So it's important to have those tough conversations with family members as well.
Absolutely. And it's another reason, even if I have a much older woman who has children,
of the depths 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 of like what's available to them and who's a good candidate for which type.
We try to preserve the breast as much as we possibly can. That should be our goal as breast surgeons. Lumpectomy or breast conservation surgery is typically the way to do that. So a lumpectomy is when we remove the tumor and some normal benign breast tissue around the tumor. So that benign breast tissue around the tumor is very important. That's called your margin. And you want to make sure that the cancer is not touching the edge of the lump. That's basically what that means. That's a negative margin. So we need to make sure that the tumor is small enough relative to the size of the breast to ensure that we can perform lumpectomy with a negative margin without distorting the look of the breast. So that's lumpectomy surgery. Same survival rate between lumpectomy and mastectomy. So if you have a small, centimeter size or really tiny tumor in the breast, there's really no benefit to doing mastectomy for that over lumpectomy, right? Unless there's a genetic issue or anything like we just talked about. So that's how I start with that. Now, sometimes we have no choice but to do a mastectomy. And so that would be if the tumor is quite large relative to the size of the breast, and it would be very cosmetically unappealing and aesthetically not pleasing at all to do a lumpectomy where you'd have, a good amount of indentation in the breast and it just wouldn't look nice. Or sometimes women have multiple breast cancers in one breast where we couldn't possibly do a lumpectomy because of that. Or there's a genetic positive result. Or in the end, after I go over all statistics and all risk and benefit, and ultimately it's the patient's decision. And if that's what the patient wants to do, mastectomy, then we will honor their choices and respect it. So when we talk about mastectomy, we can do mastectomy with reconstruction or without reconstruction. When we do it without reconstruction, that's what you alluded to. That's called aesthetic flat closure. That means closing it flat, making it look pretty. Mm-hmm. So yes. What we're doing with that is we're taking extra skin so that when we close the two edges back together, the incision lies completely flat across the chest wall.
Yes.
And that's more comfortable for the patients. And also it makes potentially a mastectomy bra where we put a prosthesis inside a better fit to have less overhanging skin. Sometimes we do that on our own as breast surgeons, and sometimes we get our plastic surgeons involved to help us take extra skin and extra fat out because it can go all the way onto the back, basically. That's a personal preference. Now, some women want to have reconstruction, and that's where we get our plastic surgeons involved. And so there's two types of plastic surgical reconstruction. One is implant-based, and the other is tissue-based. So implant-based is oftentimes a two-stage procedure where at the time of mastectomy, the plastic surgeon will place a temporary implant, which is called a tissue expander. It's basically a flattened implant, which over time, you visit the plastic surgeon approximately once a week, and they will fill the tissue expander with saline to slowly expand it to the shape of an actual implant. You want to give the skin some time to stretch out before putting a permanent implant there. And then once it's fully expanded, the plastic surgeon will take the patient back to the operating room, remove the tissue expander, and put in the permanent implant, which is a much less invasive procedure than the first time where we're doing mastectomy.
Is there a general timeline for that? Like how long someone would have the expanders?
Yeah, that's a good question. So it can be anywhere from 6 weeks to 2-3 months sometimes. It just depends how your skin is doing. Some people can get expanded quickly, and other people you need to take your time. The skin's a little bit beat up. It needs a little bit more time. We don't want to start expanding too fully, or sometimes the expansion can hurt, because you are stretching the skin. So some people may need a week off of expansion just to get to be a little more tolerable for them. So it's highly dependent. So anywhere from like 6 weeks to about 3 months, I would say that 3 months is a little on the longer side. Also dependent on whether you need other treatments after surgery. So if you need any cancer treatments after surgery, you will have the tissue expander in longer, right? So that will make a difference as well. The other side of reconstruction is called tissue-based reconstruction, which we call autologous reconstruction, meaning you're going to take your own tissue from your own body and recreate breasts from your own tissue. So you mentioned the DIEP flap, DIEP. That is where the plastic surgeon will actually take your belly, your lower belly, so skin from the lower belly, the underlying fat of the lower belly, and the blood vessel that supplies that skin and fat, and will place it onto the chest wall and reconnect the blood vessel from that abdominal tissue to the blood vessel that supplied the breast that was there. So that's a more involved operation. Obviously, you're reconnecting blood vessels. You have another incision at the bottom of your belly. It's like a tummy tuck incision, basically. So you do get a bit of a tummy tuck at the same time with this procedure. And some women are candidates for it and some women aren't. You have to have the belly fat, first of all.
Right.
If you don't have the belly fat, you're not going to be able to do that. But if you have the right amount of belly fat there, then it's definitely an option. And it is a nice option because it is your own tissue. The aesthetic look is really fantastic when you have a good experienced plastic surgeon doing that with you. It really is a remarkable cosmetic result. And again, it's patient preference. As long as you're a candidate for either, then it's really, you have to decide what's best for you.
Focusing on like the DIEP flap option for somebody, does that happen at the same time as the surgery? So you'll have the surgeon come in and remove the cancer, and then the DIEP flap happens also in that duration, or is it a second, like come back in for that reconstruction piece specifically?
Two options. Sometimes you can get it at the same time of the mastectomy if the plastic surgeon thinks you're a good candidate for that. And sometimes we do perform it in 2 stages, where the plastic surgeon will actually put that tissue expander in first at the time of the mastectomy surgery and expand the skin in the area prior to doing the DIEP flap, and then a second operation to take out the expander and do the DIEP flap. So that is plastic surgeon dependent and usually, patient dependent also. So that's where the plastic surgeon is a big player in this group. Because he or she is going to be the one that says, okay, you're a good candidate for this, you're not such a good candidate for that. And that's how they'll decide. But you can do it both ways. I find the plastic surgeons are putting the tissue expanders in prior to the DIEP flap more lately than doing direct DIEP flap. But again, that's dependent on which surgeon you choose, and also what your particular skin looks like and your belly fat looks like and the size of your breast and the shape of your breast. That's all decided by the
so many factors.
Yeah, a
so
lot of factors into account. Mm-hmm. A lot.
Yeah. And speaking of like just the tissue option also. So if you're not a candidate because you don't have enough fat or other reasons, they can go to other parts of the body as well to utilize your own tissue, right? Like I don't know what it's called, like the back of your like shoulder area.
Yeah, that's called a latissimus dorsi flap or a lat flap.
Okay.
That's where they take your lats or your muscles at the side, right? On the side of your back. They take the skin and the muscle and they actually swing it around to the breast. And that's a lat flap. That's an option. The deep flap is usually more aesthetically pleasing than the lat flap. We haven't been using those as much lately, but sometimes we're forced to. Sometimes we have to. Those are the two flaps that are most commonly used. But I would say majority we're aiming for a deep if we want to go the tissue reconstruction route.
And then like from the patient perspective too, I know when I was talking to my surgeons, I was incredibly active at the time. I like loved practicing yoga. I was a runner. It was really important for me to like be able to like do my like chaturanga push-ups again. And like all these questions about like will I have and maintain my upper body strength? Like to me, that was like my guiding principle to help me determine what type of surgery I ultimately wanted. And then ultimately I was a candidate actually for breast conserving surgery. So that actually worked out really well for me. But again, prior to knowing that, we had to explore all of these other options. And I think, and this is maybe like where I hear that like you get so overwhelmed with information overload that it didn't dawn on me that like, am I having the conversation of like just going in for one surgery, or is this going to be 2 or 3 surgeries that I'm going to have to keep coming back for? Right. And so I think sometimes as patients, we just kind of have in our mind, like it's going to be surgery. I don't need chemotherapy. I'm good. It's going to be surgery plus radiation. I'm going to be fine. But then realizing, but in 6 weeks later or 3 months later or 9 months later, you might need to come back for these other surgeries. So I think it's just really important for us to realize like, it's not necessarily a one and done, but then there might be more surgeries involved in that particular treatment plan. But one of the things I wanted to ask your advice on, or not medical advice, because we're not like in a medical setting, but just like to share in your experience, the how do I phrase this? I know like when I was going through my options, I also needed radiation. And so I was very aware of, if I had a mastectomy or needed implants, with your skin getting tighter also, and then knowing that the radiation can continue to shrink your breast, how do we balance like surgery and radiation? If you could talk a little bit, and I'm probably not articulating it as well as like, but just kind of like understanding like those relationships of like, yes, I need more treatment, but what does that mean in terms of my breast surgery?
Yes. So when we perform lumpectomy, it's not going to make much of a difference, right? To get the radiation. That's very common. Lumpectomy and radiation really go hand in hand. That's the reason we can perform lumpectomy and not mastectomy is because we add on the radiation treatment, which is what then reduces the recurrence rate to allow us to save the breast. So when we perform lumpectomy, we wait about 4 weeks for wound healing, and then we start the radiation. And yes, it can cause some skin thickening and redness to the skin. But over time, those changes should decrease. With mastectomy, now that's different. So most of the time after mastectomy, we're not giving radiation, but there are instances where we have to. And so that's where I think your question really would lie, the answer to your question would lie. We give radiation after mastectomy in women who have positive lymph nodes. And we give radiation after mastectomy in women who have very, very large tumors, very large, like 5 centimeters or more, or in certain circumstances like inflammatory breast cancer. It's an indication to give radiation thereafter. So this is where the tissue expanders come into play and the timing of your cosmetic surgery. So let's say there is a woman who has a positive lymph node who had a mastectomy and a tissue expander in place. There's 2 options. You can actually expand and radiate with the expander in. And then most plastic surgeons will wait at least 6 months until going back to the operating room to remove the tissue expander and put in the permanent implant or do the deep flap. Because you can't reoperate on skin that's freshly radiated. It won't heal. It's a wound healing issue. So that's where we really have to think about timelines. And if we know that the patient has a positive lymph node prior to going into the operating room, you already diagnosed and we know that you have the positive lymph node, you have to explain that to the patient. If you're going to get reconstruction, part of it may be delayed a good 6 months, sometimes a year. So that's important to set the expectation. It also is a reason why some women choose to go flat, right? That could affect their decision. Or sometimes the expansion gets done quickly and the plastic surgeon can swap out the expander and put in the implant, and then you radiate the actual implant. Some risks with that, but I have seen that done also, but it just doesn't always work out that way.
Right.
So you have to understand that all of these options are on the table once the once radiation is added onto your plate. If you're having a mastectomy, if you're having a lumpectomy, you are having radiation regardless, and so that is like standard for about 4 weeks after lumpectomy surgery, radiation, and most of the time the wounds do very well. The radiation we give is highly focused now, so we usually don't have any wound healing issues with radiation. With lumpectomy.
Thanks for explaining like all of those options, and I think it just speaks to the point that like the cancer diagnosis is not a perfect linear path. I joke that I was like, okay, the A-type in me was like, I need a plan, I need a date, I need to like, I'm following it, I'm on board, I like mentally like I'm ready, and then it changes, and you're like, oh my god, and so I had to embrace like all of these little changes along the way, because as you're mentioning too, even with the genetic testing or MRIs, you're constantly getting more information to make better informed decisions, but that information comes in spurts, not all at once. And so if we go back to the operating room, let's say at the time that we're doing the surgery, we don't know if there's positive lymph nodes involved, but there are techniques that you would utilize to see the extent to which any cancer cells had traveled to the lymph nodes?
The best way to try and determine that before surgery is with ultrasound. So we would ultrasound the axilla or the armpit, which is where the lymph nodes for the breast are located, and see if we saw any abnormal looking lymph nodes. And if we did see an abnormal looking lymph node, biopsy it with a needle prior to surgery. That can give us a positive result before surgery, and that can change a lot of the techniques that we use and the types of treatments that come after surgery. And with the caveat that sometimes the lymph nodes look fine on the ultrasound, and when we actually remove a few, one can be positive, and that's a result that we didn't expect, but that can happen. So the surgery is the best truth teller, I guess, of what the status of the lymph nodes are. But yes, the ultrasound is a very good tool to try and get an idea prior to surgery.
When you remove the lymph nodes during surgery, this is just so fascinating to me. I feel like I would love to be like an intern and just kind of see like what happens in the operating room. Do you test the lymph nodes right then and there to see if they're positive?
Okay, the answer to that question is most of the time, no.
Okay.
That's called a frozen section. So that's basically where we send the lymph nodes to the pathologist, and they do, I like to call it a quick check on the lymph nodes, and give us a call in the operating room and let us know. Most of the time we're not doing that, especially when we're not expecting a positive result, because it's a good indicator, but it's not as accurate as the formal processing that the pathologist will do on the lymph node itself. Other times we are, and this is when we know that there's a known positive lymph node prior to surgery. And there are techniques that I use to try to remove the least amount of lymph nodes as possible, even if a patient has a positive lymph node. So this is called a targeted dissection, where I will remove the known positive lymph node and a few more lymph nodes and send those to the pathologist. And then depending on how many lymph nodes are positive, I can either stop surgery and not remove anymore, or I have to move forward with a full dissection of the lymph nodes. So that's where an intraoperative result would really make a difference. And so that's when I'll utilize frozen section or intraoperative check. But most of the time, the majority of the time, we're not anymore, because we are doing less and less full lymph node dissections as more and more data comes out that less armpit surgery is actually better for the patient, which means less lymph nodes removed.
Absolutely. And I'm so glad to hear you say that also. And it's so funny to hear, and well, it's not funny, but so my surgery, I want to say, is about like 7 years ago now, and how much technology and data and treatment has changed from my own experience. And so I did have positive lymph nodes involved. I knew that prior to going into the surgery. I knew I was going to have a full axillary node dissection. Like that was just like the practice at the time. And now talking to people, or even going to the San Antonio Breast Cancer Symposium or the surgeons conferences, et cetera, like you're hearing that that's no longer like the standard and that we're trying to preserve. And I was like, oh my God, like that's so amazing. Like sucks to be me because now I have lymphedema and all these things. But like at the same time, I'm so happy for everyone who has unfortunately been diagnosed after me and has these options as well. So thanks for just like reiterating that, because I know a lot of us get really nervous about the longer term side effects. I joke, you're either managing to not get lymphedema or you're managing because you have lymphedema. So either way, it's in your life.
Yeah, you're thinking about it, right? And yeah, that was really important data that's been out now, where even with a positive lymph node, I am oftentimes not doing full axillary node dissections any longer. And it's important that you have a breast surgeon that understands that.
Yes. Yes.
It's
newer. Just like conserving the breast too, like conserving the lymphatic system. So
correct.
Well, we got into like a lot of the nitty gritty. I really appreciate you taking the time to like talk about, the definitions of not just the surgeons and the people on the team, but the types of surgery that people can have. I would love to ask, like, from your opinion, what questions should patients be asking their surgeons? A lot of times we don't know what we don't know or what to ask. On our website, we do actually have a PDF that people can download with questions to ask their surgeons. I would love to actually run that by you, because I'm sure there's questions in there that we're missing as well. But if you're advising any of our listeners, like what are the primary questions we should have on our radar?
I think you need to understand, what the surgery really involves, where your incisions are going to be. Are you going to have any drains? That's a good question to ask. What is a drain if you need one? Can you please explain it to me? How long does it usually last? I'm going to talk about the surgical aspects now. Why are you choosing the surgery? What's the difference between lumpectomy and mastectomy? And is there really the same survival rate? Is a mastectomy, am I going to live longer if I have a mastectomy? So that you understand that we're not just saying, oh, just remove the lump. And a lot of people really think that removing the whole breast is better, and it's not. I think a lot of questions should be about the postoperative recovery. What to expect? What are my limitations? What, restrictions of movements, heavy lifting? When do you think I'm going to get back to being able to go to my exercise and yoga class? What kind of bra should I be wearing? Are you going to give me a bra, which we do? A lot of patients buy, zip up shirts or button down shirts. And it's just something that you wouldn't think of, because putting a shirt over your head might be difficult if you're having armpit surgery, right? It hurts. Sometimes there's pain. How much pain am I going to have, right? That's a great question too. Am I going to be in pain? How are you going to help me with my pain? Am I going to have any long-term limitations in terms of arm movement, range of motion? And what do you do to help me so that doesn't happen? Which we have all of our patients have early PT involvement. Yeah, that's something that we're trialing actually at my hospital now. Just any signs of, it's really the criteria is not strict at all. Any like limitation, basically, into PT really early, even though you might not be able to do the strenuous exercises because you're still in that immediate post-operative period, but start the learning process of what are the exercises that I can do to get my range of motion back? Start that early. I think that those are the unknowns, and it's, you can't just say to a patient, well, you see, after you have the surgery, you'll see how you feel. You can give them as much information as possible about how you may feel, what the level of pain, what the level of restriction is going to be. So I think, honestly, the day-to-day things that you take for granted, lifting a gallon of milk up, right? Can't do that after surgery. Questions like that, I think, are important so that you're not surprised when you get home from the operating room.
That's really, really powerful. I appreciate that. I was like scribbling some notes down here for myself as well to add to our like questions. But, I think focusing on the post-op, right? Because we want to wake up from surgery and be like, okay, we're done. Like we got through this cancer thing, the cancer has been removed, but knowing that there's this, like you're not done. There's a lot of recovery that happens. There may be additional treatments, there may be additional surgeries afterwards, going back to the fact that it's not necessarily always a linear path. I remember two things that I love to share with people is that I'm a huge coffee drinker, if you can't tell. And so as I've been drinking my coffee throughout the podcast, but for me, that was a big deal. So like I literally took all of the big cups on the top shelf and put them on the lower shelves because I wanted to be self-sufficient to be able to pour myself a cup of coffee in the morning. Like I wanted to like be able to do that. And so just the idea of like reaching up to like the top shelf was going to be a limitation that I knew was going to like bring me to tears because it was like, now I have cancer and I had to go through surgery. Now I can't even have a cup of coffee. And then the funny thing that you were mentioning too about the gallon of milk, I remember this, and I never thought about this before in my life, but the suction of the refrigerator door. I remember being able to open the refrigerator door. I was like, ooh, that definitely hurt my pectoral muscles. Like you don't realize how much you use your upper body strength in all these little things. And I'm like, honey, can you get something out of the fridge? Because like I literally can't open the refrigerator. And so I think having these honest conversations with the patients and not to sugarcoat it, because if we can then plan for babysitters, like knowing that I can't pick up my kids and like swing them around or all these things, like, how can I plan for this and then know the actual not sugar-coated duration? I can adjust for that in my own life. And so I think that's really helpful.
Absolutely. And that was smart thing to do
Yes.
with the coffee cups. That was very smart. And that's what I mean. It's those day-to-day things that we will take for granted because it's routine. It's routine. And then all of a sudden you're restricted. The nice thing about what you had done, the breast conservation lumpectomy surgery, is that it's not that long, the restrictions. Usually about 2 to 3 weeks. And so that's the fastest recovery you can do for breast cancer. But still, 2 weeks of not being able to open the refrigerator door because of the suction, it's, you have to
it's
be
frustrating. Small little things.
And it's frustrating.
Mm-hmm.
Exactly.
Right. Not the end of the world, but just like the small little things. Exactly. And I did not know what these drains were, the JP drains. And so I think having a doctor explain to them what the drains were, and I understand that like, this is your world. And so, I think a lot of times our medical doctors are utilizing terms that are commonplace in your practice, but for us, we're hearing about it for the first time. And so to describe what these drains were, I think it was like, and I had 3 of them, even though I had a lumpectomy, because I had the full axillary node dissection and then aesthetic surgery on the other side to kind of make things more parallel. I ended up having 3 drains. And so they were like these little tubes and like snakes literally coming out of my skin into like little bulbs of like for the drain to collect the fluid. And I am so squeamish. I cannot deal with pain. That was like my biggest, scariest moment. And then I was like, wait, what? And then I started looking at YouTube videos. I was petrified. But I have to say, like, it's amazing how your mind can overcome a lot of these like squeamish things. And like I remember my husband was like, oh, I can help you like milk the drains and help you with this in the bathroom. And I'm like, I need to do this by myself because I didn't want anyone pulling or tugging or any of those little things too. And so I don't know, are there any like tips that you recommend for people who are going to have these drains and how to like manage them? Because they're more of a nuisance. They're not painful. They're just a nuisance.
Okay. So the one of the things that I do, when I see the patient and I know they're going to have a drain or there's a possibility that they're going to have a drain, I actually draw it on a piece of paper and show them exactly. And I have one in the office too. So I explain to them part of the drain is on the inside that you won't see. And then this is actually what you're going to see coming out of you on the outside. So I'll show them the tubing, I'll draw the tubing, and then I'll show them the actual bulb. And I really emphasize, you are going to see this. Okay? Because a lot of times people think it's just underneath, but no, this is actually coming out of you. It's going to be stitched to the skin. And one of the things I do recommend, the bra that we give actually has a pouch to put the bulb in. So the the tubing isn't hanging. It's in a pouch. So making sure that you have a surgical bra that has pouches in it is helpful. I show them how to, we actually do drain teaching before you leave the hospital, but I'll show them in the office too. How to open it, explain to them you're going to pour it into a cup, a measuring cup that we're going to give you. You need to measure it in cc's or milliliters. Here's a piece of paper that we give you. You write down how much comes out each time you empty it. That's how I know when I can remove the drain. Explain to them that it's going to be removed in the office. This is not another operation. It takes about less than a minute to remove the drain. I explain to them that patients don't like them. Patients don't like the drain. I said, look, you're not going to like it. I'm going to be very honest with you. It's going to be annoying. You are not going to like the drain. Just to be very honest, and they all come back and say, you're right. I hate this drain. Like it is, but you can handle it. And that's what they will. I can handle it, but I don't like it. That's totally reasonable. So explain how the drain works, what it looks like. Get the bras. If you want to get another bra that has pouches for the drain, get that. They also make, which is, you can get it on Amazon. It's a little holder that goes across your stomach. So
it's like almost like a tool belt, right?
Yes. And it's a net. It's a net-like material. And so you can shower with the drains in. So you put them in that net. So something's holding them so that you can actually shower. Because think about it, especially if you have one on each side, it's pretty hard to shower with them. They're going to be hanging, and that's going to be actually painful if they're hanging down like that. And so that's another thing that I explain to them for showering purposes. You can get one of these. I think it's really about what you said before. It's being honest, being really honest, and not sugarcoating. You can be empathetic and sympathetic while being truthful at the same time.
Is there anything that we haven't covered? Like, we talked about so many things. This is phenomenal, Dr. Tamero. I really appreciate it.
I love talking about it. So
yes.
Anytime.
So thank you for being on the show today.
Oh, you're welcome. Would love to come back. Thank you for having me.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400+ programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.